Hey, this is Doug Fields, CEO of the Institute for Healthcare Consumerism, along with my co-host Brent Macy, Managing Director, and welcome back to the segment of Healthcare Consumerism Radio. We have joining us today to talk about value-based insurance design and its application to high-deductible plans. Dr. Mark Fendrick, Director of Center for Value-Based Insurance Design at the University of Michigan. Hey, Mark, good morning to you.
Thanks for having me. It's a real pleasure.
Hey, it's good to have you here, Mark. Even though I'm a Buckeye grad, Mark, it's glad to have you here. Hey, Mark, listen, I know you've worked with Roy on some of this and others, and, obviously, as you well know, we're, good friends of Roy's. He's been a member of League of Leaders for a long time. Take our audience back to kind of the foundation and talk about value-based insurance design, and then let's talk about how it can apply to high-deductible plans.
Well, thanks. Value-based insurance design, or VBID, is a concept that's come out of the fact that as Americans have been asked to pay more and more out of pocket for medical services when faced with increased levels of cost sharing, not only do they not buy the services that I would not think they need as a practicing primary care provider, but they're also showing increased likelihood to not buy the things that I beg them to do, the highest value services in healthcare, such as immunizations and screenings and treatments that manage chronic disease and keep people out of the emergency room and the hospital. Over 14 years ago, the private sector, largely driven by large businesses, started adopting our idea of value-based insurance design, which sets consumer cost sharing not on what services cost, but what value they provide to the individual consumer and the organization. So the basic premise of VBID, Doug, is to remove or lower barriers to those high-value medical services that pay off not only in terms of health, but often pay off in terms of lower aggregate healthcare costs.
Right. So tie it together with high-deductible plans now.
Right. So as your audience well know, that services or benefits meant to treat, and I quote this from some guidance, an existing illness, injury, or condition, end quote, are excluded from first dollar coverage or coverage outside of the deductible in an HSA-eligible high-deductible health plan.
Right.
And as you know, not only is most of the healthcare spending in the United States based on chronic diseases, in my opinion, being a student of the healthcare system in terms of not performing in terms of quality, this is where the largest leaps that we could have if we were to truly transform the healthcare system. So it has been our intent for quite some time to change the definition of the term prevention in HSA-Qualified HDHPs that would include some of those clinical services that are not primary prevention but do manage existing illnesses or conditions, which we know individuals are systematically underutilizing in some of these products. And at the same time, if they were to use them more often, in some situations, total healthcare costs would actually fall.
And the other side, too, is that we run the risk with people in high-deductible plans of discouraging, patients with chronic condition from avoiding, the care that they need, correct?
Right. I mean, I've always been impressed in terms of the ability for high-deductible health plans to preserve the well-documented capacity to engage consumers.
Right.
But at the same time, we've really tried to push this idea of clinical nuance in benefit design, which is that, medical services strongly differ in the clinical benefits they provide. And terms like prevention that are bandied about, and we know that most plans now are mandated to cover primary preventive services before the deductible at no cost sharing. But in some examples like mammography or colonoscopy, I would argue quite strongly that the follow-up colonoscopy in a patient at very, very high risk of colon cancer is substantially more valuable than the free colonoscopy I got when I turned 50. So what we're really trying to do is expand the term prevention to actually have an encompass value, not only in terms of cost savings, but also in terms of the amount of health these products may provide.
Mark, what's the progress or lack of progress? What's the current update as to how you feel, the ears that need to be listening are listening to make these changes and redefine,
Well,
prevention?
we've been very fortunate, including having engaged a number of your member organizations to promulgate this idea that expanding the definition of prevention and high-deductible health plans would be a good thing, not only for patients, which is the driving force for me, Doug and Brent, but also I believe this would be good for employers. This would be good for the healthcare system at large, and I believe that our white paper, which we recently produced with the support of the West Health Institute, would lead to a substantial shift of individuals into the high-deductible health plan marketplace, which would lead to, in my opinion, a overall reduction in healthcare costs in a generalized population, and lead to a significant shift about how employers view their healthcare expenditures.
And I think that, you know, if we read all the predictions, and, you know, we're one that says it too a lot of times, and you got two dynamics happening out there. You got, you know, the evolution and maturing of full replacement programs inside employers, high deductible HSA, high deductible plans, and we've got the emergence of private exchange as a very viable, you know, benefit distribution platform. And within those exchanges, it's predicted that HSAs and high deductible plans are going to quadruple, you know, over the next 3+ years. So I think this is very, very important as relates to where we're moving with majority adoption, you know, of high deductible HSA and high deductible plans.
Yeah, I couldn't agree with you more. I just think this creation of a hybrid HSA-Qualified HDHP with VBID elements to make sure that there are not really high barriers for those beneficiaries to get access to the highest value clinical services that fall outside of the prevention definition would be extraordinarily helpful. I could tell you, Doug, that you know, my patients come into the office in the first quarter of this year, and because they're facing somewhat steep deductibles in a lot of these products, they tell me point blank that they're not willing to fill prescriptions or for diabetics to get their eyes examined until they have a better understanding of what their year-long expenditures are going to be.
Now, Mark, this is Brent. When you know, there's a lot said about the high deductible plans out there, or HSAs. They're only for the healthy and the wealthy. Would you agree or disagree with that statement?
Well, so the answer is I want to change the plan design such that a really well-informed consumer of health care, regardless of being completely healthy or having a chronic disease, would get into a situation where these individuals are actually encouraged to engage and become informed about where their health care expenditures are going. I do think that most of the evidence from EBRI and elsewhere would suggest the clear attractiveness of these products for people without a lot of chronic underlying diseases. We do, we do feel strongly that the allowance of certain evidence-based secondary preventive services in these products would make the HSA, HDHP much more attractive to this very large and growing population group.
Now, in the document, Mark, that we have here with the study that you did with West Health is you guys are going to have a chance to go present a lot of your findings to the administration on Capitol Hill in the coming months. Is that still on track to happen?
That is our plan. You know, I like to joke that I went to medical school to learn how to make a presentation to the Internal Revenue Service and the Department of Treasury. But as you both know, Brent and Doug, that we have a very broad stakeholder coalition that agrees with this.
Yeah.
It's one of the few ideas that I could honestly say has bypassed a lot of the rhetoric that goes around partisanship. And because, as I said earlier, it seems to be so intuitive, and the initial regulation was not intended by any means to preclude these high-value services that make Americans much healthier and actually in some situations lower cost outside the purview of the services that should be provided in these programs.
Yeah. And I think would you agree, there's no real magic pill out there, but it's, I think if a lot of people look at the healthcare system, there are issues there, obviously. But this, reading this, and our audience can find this on our website as well, this makes a lot of sense as a type of reform, if you want to use that word, to the system, right?
Yeah, absolutely. As I said, it really comes down to a couple sentences in an IRS guidance. And as a clinician and not a tax lawyer or a policymaker, this just seems to be an unintended consequences of some early discussions about getting these programs off the ground. Listening to the earlier speakers and earlier episodes of your radio broadcast, I think there is some consensus to say that a slight, and I want to make sure I say that clearly, a slight liberalization of this program to allow the services for which I am benchmarked as a high-performing provider. Mm-hmm. It makes total sense if you're going to pay doctors to do certain things more often. You should probably build benefit designs that make it easy for the patients to do the things that the doctor is recommending.
Hey, Mark, if we have listeners today that want to kind of get behind what you're doing, how do they do so?
Well, the good news is value-based insurance is under VBID. Mm-hmm. If you just Google VBID, Vehicular Born Incendiary Device, mm-hmm. We passed that in 1999. So you could find our University of Michigan Center, www.vbidcenter.org, easily, and you'll find the report that you mentioned on the role of VBID in HSA high-deductible health plans. We have also done a number of pieces on specialty pharmaceuticals, as well as the role of absenteeism and presenteeism issues that you've addressed in this forum in the past. You could also follow us on Twitter at @UM_VBID, where we are addressing these issues on a regular basis and see quite an active dialogue in the fact that as an academic venue, we really don't have a very strong position, except we want to strongly increase the value that we get from our trillions of dollars spent. And given the timing of this week's radio show coordinates with the latest Commonwealth Fund report suggesting, different from our soccer team, which is doing well, our healthcare system is still performing at the bottom of the westernized countries that they seem to be comparing on a regular basis.
Mark, listen, I really appreciate you joining us, and you bring some really valuable pieces here to the Institute, and we thank you for that, both what you've done in our program, to our web community, and now here on our radio program. I look forward to having you on again sometime soon.
Well, that would be my pleasure, and we're trying to engage with your members and your listeners as often as we can, and I hope some of them reach out to us either through our website or through our Twitter feed.
All right. Sounds good, Mark. Listen, you have a great weekend. To our audience out there, as Brent alluded to earlier, right now we have a very unique summer savings program for IHC Forum West. You can sign up to 10 Forum West, which can be very well timed, November 10th, 12th for $99. Go to our website, www.thatihccforum.com. Thank you all for listening today, and we'll see you next week on Healthcare Consumerism Radio.